Okay, so today we'll be talking about urologic stones and the microbiome. I'm Ryan. I'm one of the first year residents here at the UBC Department of Urologic Sciences, and we will begin. So I don't have any disclosures. And our learning objectives today will be to provide an overview of the human microbiome with a focus on gut and urinary microbiomes, to review current literature examining stone disease and the microbiome, and to discuss the role of optimizing the microbiome in recurrent stone patients. And as I'm sure many of you are already aware, long before the days of CareConnect and Cerner, Hippocrates is often credited as one of the first to examine urine and its association with various disease states, probably most notably that of diabetes. But in his book, Aphorisma, he drew upon the association between cloudy urine and fevers, which may be the first document to look into the diagnosis of urinary tract infections. So just a bit of history trivia to start us off. And then moving on to the epidemiology of stones, according to the National Health and Nutrition Examination Survey data, the prevalence of stone disease is about 12% in men and 10% in women lifetime. And amongst those, you can expect 30 to 50% having a recurrence within 10 years of initial symptomatic stone event. And with regards to stone composition, calcium oxalate is by far and away the most common, with 70 to 80% of stones being calcium oxalate. Next, with being struvite at 10%, uric acid and cysteine at 7 and 2% respectively. And with regards to recurrent stone former patients, we, according to the CUA guidelines, some lifestyle modification that you could make after addressing various disease-specific factors would be to have some dietary modifications, including fewer red meats and fewer high oxalate foods, more fiber-rich foods, keeping sodium down below 1.5 grams per day, having a moderate calcium intake per day, increasing your fluid intake to 2.5 liters a day, and addressing obesity and metabolic syndrome, all of which are risk factors for developing stones. So then moving on to the Human Microbiome Project, and as I'm sure many of you are aware, this is an NIH-funded study currently taking part in 2 different phases, on its second phase right now. The first phase, which pertains to the urogenital system, took place from 2007 to 2016. It involved 300 healthy individuals with 5 anatomic sites. Their main method of determining the different species involved 16S ribosomal RNA sequencing. And in total, from these 300 patients, we have 32 terabytes of data publicly available for research use. And then prior to the Human Microbiome Project, there was little focus on bacteria and bacterial ecosystems and its effect on human health as a whole. So it's nice to have this data available for us to look at. Now, looking at the link between the microbiome and urology. So primarily, there's going to be discussion around the gut and urinary microbiomes, as I had alluded to earlier. And so when talking about the microbiome and urology, a lot of the time our minds kind of jump towards struvite stones and infective stones and its associated urea splitting bacteria. And so here we see the typical kind of bilateral staghorn sign, often associated with struvite stones. But for the purposes of this discussion, we're going to be leaving that out of the picture. And we'll be focusing more so on calcium oxalate stones and calcium oxalate metabolism. In regards to recent studies, there's been more talk about this gut-kidney axis, as well as its role in chronic kidney disease and the metabolism of uremic toxins not typically removed by dialysis, which is another area of focus, which is gaining some traction now. So looking into antibiotics and its association with kidney stones as kind of our first foray into how bacteria will affect stone formation. This is a paper from the Journal of the American Society of Nephrology. This demonstrated, this was a case control population-based study which used data from the UK from 1994 to 2005. I looked at 12 classes of oral antibiotics and its effect on nephrolithiasis. And so even after controlling for comorbidities and other medications, several classes of antibiotics were associated with increased odds of nephrolithiasis, with the greatest odds taking place within the first 3 to 6 months after exposure. And as you can see here, broad-spectrum penicillins, nitrofurantoin, fluoroquinolones, cephalosporins, and sulfamethoxazole were probably the biggest culprits. Again, with the blue lines here denoting the more recent 3 to 6 month time frame where stones were found to have developed by, with the odds ratio going up to about 2.5, 2.7. Now on the right here, this is actually showing a breakdown of age-related data. This effect was even more pronounced when you're looking at antibiotic exposure in younger patients. Kind of giving some context, there's been an increase up to about 70% bump in the incidence of kidney stone disease in young patients, adolescents, and teenagers. And this is thought to be kind of correlated with the trends of increased antibiotic prescribing down in the United States. And so we can see here too that, exposure to sulfa way early on in the teenage and young childhood years brought up to about even an odds ratio up to about 30 for developing stone disease later on. So this is just some data. We'll talk about the pediatric population a little later in a different study as well. Some of the typical methods for examining the microbiome classically have been using a combination of PCR-based sequencing and culture-based methods. 16S ribosome RNA sequencing has also been used, as we saw with the Human Microbiome Project. Previously, there was also culture-based taxonomic classification, looking at different characteristics of different bacteria and classifying them in that regard. But now the world's kind of shifting towards large data, shotgun sequencing, big data sets. And so we're seeing an increase in the types of studies that utilize meta-genome-wide association studies, metabolomics, metatranscriptomics, metaproteomics are all on the table now. Its use now in clinical research is still quite young, and with the increased cost, it does pose a barrier for a lot of researchers, but it is something that's coming up on the rise, and as a result, costs are expected to come down. So now we're talking about calcium oxalate stones, and in particular, its association with Oxalobacter formigenes. So as you recall, calcium oxalate stones are the most common stone type. Oxalobacter formigenes is a gram-negative bacillus, which lives symbiotically as part of our normal gut flora in many individuals. It's an obligate oxalate consumer, so it has to utilize oxalate to live. And it does so using oxalyl-CoA decarboxylase and formal-CoA transferase. Now, these enzymes were also used as a marker for oxalate degrading abilities when examining other species of bacteria present in other studies that we'll touch on a little later. So historically, most research between gut microbiota and kidney stone disease focused on Oxalobacter for the reason that they were the first bacteria isolated from the gut, shown to be obligate oxalate consumers. And so interestingly, Oxalobacter may also stimulate oxalate secretion in the gut, as found in a study by Hatch in 2006. This is important because there's also endogenous oxalate production by us in our livers. And so this is thought to also produce or also result in decreased circulating levels of oxalate and therefore decreased urinary levels of oxalate. And so some of the early studies noted that Oxalobacter was deficient in stone samples in some recurrent stone-forming patients, which opened the door to further research into this area, thinking that there was a causal relationship, and also going down the rabbit hole of looking into probiotics, which would help to replenish Oxalobacter as a way to prevent recurrent stone disease. However, subsequent studies have shown that even in some recurrent stone-forming patients, there is Oxalobacter present. And as we'll see here in this next slide, Oxalobacter also is either present but also not present in some non-stone forming healthy individuals. So kind of looking at it from a broad scale, there's no significant difference in Oxalobacter itself in stool samples between groups, with 8 to 100% found in stone patients and 11 to 100% in healthy patients. So there's really no clear line drawn just from Oxalobacter alone. There was a trial in 2017 by Hopp, which looked at using Oxalobacter as a probiotic for 8 weeks, but it did not reduce urinary oxalate, which is ultimately the endpoint that we're trying to achieve here. Nonetheless, Oxalobacter probiotics are still being sold on the market in some countries, despite this finding. As far as I know, in Canada, it's not something that's recommended, though. And now there's a study by Miller et al. In 2019, which performed a network analysis looking at Oxalobacter and its related taxa. And it was shown there that when you look at Oxalobacter and some of the associated bacteria with it in the gut, it's better at predicting patient versus control when looking at when compared to Oxalobacter alone. Going back to the probiotics, it's thought that this wasn't fruitful because when the patient didn't have a favorable environment for the spontaneous growth of Oxalobacter to begin with, providing the probiotic would likely not provide lasting colonization. Interestingly, though, in rat models, there was fecal transplantation studies which used a sample known to contain Oxalobacter, and this actually led to long-term colonization and decreased urinary oxalate levels. So perhaps there is something there, but it may have to do with other bacteria present in the sample to help with supporting Oxalobacter growth. Moving on to microbial biodiversity, looking at this kind of network style study and looking at beyond just Oxalobacter. There's on a large scale metagenomic wide association studies, the gut microbiome of healthy individuals appears much more diverse than that of their stone forming patient counterparts. As well, there were significant differences in the composition of these microbiota, detectable down to the specific genuses. On a systematic review by Stanford in 2020, on the figure to the right, adults with kidney stones were more likely to harbor Bacteroides, less likely to have these 8 other taxa present in their gut microbiome. Additionally, mentioned in the systematic review, there was a handful of species identified which had the ability to degrade oxalate, which were not previously described, and those would be E. coli, Eggerichella, Roseburia, Bacteroides, and the Clostridium citrinae. This indicates that there's likely a community of bacteria that are responsible for oxalate degradation, and further suggests that Oxalobacter shouldn't be our one-stop shop anymore for research associated with oxalate degradation. And changing gears now, we'll be looking at butyrate. Butyrate is a 4-carbon short chain fatty acid utilized by many bacteria in our gut. It's known to be a mediator of inflammation. It maintains the gut mucosal barrier, and it's been previously examined in inflammatory bowel disease with decreased butyrate expression and decreased butyrate concentrations are in our gut being correlated with Crohn's disease and ulcerative colitis. Relevant to our previous discussions, butyrate is also responsible for regulating the expression of SLC26, which is a oxalate transporter in intestinal cells, and therefore it has an interplay there with oxalate metabolism. In this 2020 paper, again from the Journal of the American Society of Nephrology, this is a case-controlled study which enrolled 88 children and adolescents. They performed shotgun metagenomic sequencing and metabolomics on stool samples of kidney stone patients and matched controls. They found that kidney stone formers had significantly less diverse gut microbiota compared to their controls, which is consistent with the findings that we had in adult populations. In particular, they found 31 taxa to be less abundant amongst individuals with stones, 7 of which were responsible for producing butyrate, and 3 of which were responsible for degrading oxalate. Additionally, when they were looking at the metabolomics of this part of the study, they also found 18 different metabolites, which were expressed in different levels, or which were found in different levels between the two groups, with 10 having increased and 8 having decreased in stone formers compared to their normal healthy counterparts. And so all of our discussions so far have been focused on the gut microbiome, but looking now into the urinary and stone microbiome, very few studies exist. There was a meta-analysis performed by the Miller Group again, which looked at the urinary microbiome, stone microbiome, and gut microbiome, all 3 of these, and how they relate to different patient factors, as well as like their past medical history as well. In this study, they found that lactobacillus was associated with healthy individuals, which is denoted by this purple line on the diagram to the right, purple meaning that it's found in higher concentrations in the control urine, as well as Enterobacteriaceae being associated with stone patients, as well as Veillonella, denoted by the orange line in the urinary stone disease, the USD, urinary stone disease urine. There was a significant association between stone composition and the urinary tract microbiome, interestingly, but not the gut or the stone, which interestingly may suggest that there may be a local effect on the urinary chemistry along the urinary tract, which is modulated by the urinary microbiome. However, those same bacteria would have little effect on the actual formation of the stone, as there's no association between the stone microbiome and the stone composition. So that's kind of where we're at with the current research. The data, some of the findings that I had come across during the readings for this presentation outlined that the data currently is limited by differences in the methodology and absence of available sequencing data. And several of the papers actually called for standardization of methods for data collection, sample collection, and sample processing in order for them to have more kind of robust studies involved. The meta-analysis specifically was calling for standardization of methods because they looked at many more sites of microbiome, including the stone in the urine, which weren't present in a lot of previous research. And so having a standardization process would allow for better collection of data and ultimately some better conclusions to be drawn from here. And the way that the current research is moving towards doesn't seem to be focused anymore on single bacteria species, as we were previously looking at Oxalobacter, but rather looking at a network analysis, looking at it as an ecosystem standpoint as opposed to individuals. And so that's what the picture there is supposed to try to express. So we shouldn't be looking just at the trees themselves, but the forest as a whole, as it represents an ecosystem, and and everything there is supporting each individual tree. And so we'd certainly be amiss at a UBC presentation talking about stones if we didn't talk about the Stone Center a little bit. So we know Dr. Chu, who's here in the audience, I saw earlier, and that's Dr. Lane as well on the right. And the Stone Center here is an active center looking at both the clinical and the lab aspects of stone disease. There's a current ongoing research study which goes into a lot of the things that we talked about today, the correlation between excretion metabolites in urine and bacterial microflora in patients with urinary stone disease, as a study that's currently recruiting and led by Dr. Chu. And so thank you very much for listening to this presentation and being here with me today. I'll be happy to take any questions if there are any in the audience.